Okay, good afternoon, everyone. And good afternoon to everybody online. Welcome back. I hope you also had a good lunch at home in your pajamas with your nice tea and coffee. I love the idea of the virtual option as well. And for those of you in your pajamas here today and live, it's all good too. So the afternoon is going to be what I would call the spicy side of endometriosis, and we start with our spicy OBGYN or gynecologic surgeon, Dr. Jamie Kroft, who will be talking to us about surgery. Then we get even more interesting with Dr. Kablansky. Then we'll finish up with a friend, a colleague, a great researcher. Please do not want to miss that, Dr. Serena Corsini-Mutt. So Dr. Jamie Kroft is the Deputy Chief of the Department of OBGYN at Sunnybrook Health Sciences Center, Associate Professor at the University of Toronto. She specializes in MIS and is part of the AGL Fellowship Training Program. She is the current president of CanSAGE, the Canadian Society for the Advancement of Gynecologic Excellence, and has really also helped spearhead some of the support and funding for endometriosis advocacy and education. And hopefully we're going to see some more funding coming through soon to continue to advocate for this type of work. And so thank you, Dr. Kroft, for walking us through the surgical approach to endometriosis.
Thanks so much, Sony, for that lovely introduction. I'm really happy to see all of you here today, and I'd like to thank Sony for organizing this, as well as the SOGC and everybody there that was instrumental in putting this day together. I think it says a lot that we have a full day about education around endometriosis, and I'm so happy and thrilled that we have that. It's definitely a topic near and dear to my heart, as it is to all of our speakers today, as something that you know, I've invested a lot of my career into, both medically and surgically. So that's my disclaimer I always say, is that I love treating patients with endometriosis, and I know that that's not shared by a lot of our other colleagues, and I think that's because it's such a difficult, challenging condition to treat, both surgically and medically. So hopefully I will educate you today a little bit more about surgical management of endometriosis. These are my disclosures and how we are mitigating potential bias. So for today's talk, here are the learning objectives. I'm going to talk about pros and cons of excision versus ablation surgery, and hopefully give you some tips and tricks for both. We're going to talk about optimal surgical treatment technique for endometriomas and hopefully be able to perform them in a more fertility preserving and hemostatic manner, and to compare surgical treatment options for deep endometriosis and the multidisciplinary approach required. And you know, as I said, I love treating endometriosis. I love operating. I've always loved surgery. As I think a lot of us do, because we're in this surgical field, but I still always approach management of endometriosis as a medical first, multidisciplinary management, and I think that's really important. That's what I tell patients too. I always like to be as conservative as possible. But if we need, you know, sometimes there are cases where we need to operate. And basically the main indications for surgery at this point are if patients if they find that medical therapy is ineffective. When I was a resident, and even up to a few years ago, we always used to say if patients failed medical management. I've really stopped saying this because it's not a failure on part of the patient. It's that the medications are ineffective. So I've really switched my language, and I think it makes a difference as well with patients. So if they find medical treatments ineffective, or the other main time where we find ourselves operating is if patients are trying to conceive, and all of the medical therapies will inhibit pregnancy, and that's a time where in certain indications for fertility, not all, but we'll talk a little bit about that as well, surgery sometimes is indicated. Or, of course, if you have to make a diagnosis because there's some concern for potential malignancy or pre-malignancy, especially in the setting of an adnexal mass, or if patients decline medical treatment for whatever reasons, and there are some patients that have significant side effects with a lot of the therapies. And there's lots of tools for surgical management, and my good friend Sony Singh often, jokes with me that I love the laser, and I do love the carbon dioxide laser, it's true. But really, you can use any tool when doing this, and everybody has their favorites, and it's just about getting used to whatever tools you have available or like to use, but you can have the same outcome no matter what fancy or less fancy tools that you use. So first question I have for the group, and feel free to raise your hand. If you treat endometriosis, what surgical technique do you use? So please raise your hands. Mostly excision. Mostly ablation. You can raise your hands. And what about excision and ablation? All right, so I would say a lot of excision, a lot of mix of both. So when we're looking at just what the evidence is for laparoscopic surgery to treat endometriosis versus just a diagnostic laparoscopy alone, to see, does surgery work? Do patients get improvement in pain? And there was a Cochrane review from 2020 that looked at this question, and the outcomes in terms of pain as well as quality of life showed that, and Dr. Annie Chen showed this in her talk, that they found an uncertain effect on overall pain and quality of life at 6 and 12 months, but the studies that were included were very small RCTs. There was only 2 with a very limited number of patients, and so the evidence is a weak recommendation and very weak recommendation. So I think that we have to look at the whole picture, and certainly the ASHRI guidelines from Europe say that there is likely an improvement with surgical management, and it depends on the whole patient picture. And the other outcome that they looked at in this Cochrane review was pregnancy rates, and they did show an associated increased viable pregnancy rate. Note that that's not live birth rate, but intrauterine pregnancy rate, and that's for stage 1 and 2 endometriosis. And then this is a topic that always comes up, especially as an endometriosis subspecialist who sees a lot of patients with endometriosis. They're online, they're on community forums, Facebook groups like Nancy's Nook, and they are all being told that they have to have excision surgery and they have to see an excision specialist. So what's the evidence for excision versus ablation? Again, it's weak evidence. It's a small number of RCTs, and 2 of them only look at superficial disease for stage 1 and 2 endometriosis. 1 RCT included stage 3 and 4 endometriosis, but actually there were no patients with stage 4 endometriosis that underwent ablation treatment. And this is because, and what I always tell both patients, trainees, is that it's impossible to compare excision to ablation because you cannot ablate all the endometriosis in the setting of a patient with stage 4. So the reason you can compare with stage 1 or 2 disease is it is possible to treat all stage 1 or 2 disease in certain circumstances with ablation, but sometimes it's not. And the benefit of being able to perform excision surgery is that if the endometriosis is overlying the ureter or the bladder or the bowel, you can't ablate that. You're gonna damage those important structures. So you need to excise it. But if you actually get out all the disease, it probably doesn't make a big difference whether you ablate it or excise it. And when we talk about ablating it, we're not talking about cauterizing it where it's still left. We're talking about actually destroying that tissue with a wide margin and getting down to normal tissue underneath. So I think whatever technique you use, the main important thing is to remove all the endometriosis that's there. The other benefits are that obviously you can get a pathologic diagnosis, and we know from some studies that it is hard to necessarily rely on the surgeon's eye, and sometimes we think something's endometriosis, it's not endometriosis, so it is nice to get a pathologic diagnosis, as again, the excision allows you to remove all disease, even if it's close to important structures, as well as deeply infiltrating endometriosis. As I mentioned, it would be impossible to treat that adequately with ablation. So if you're doing excision, some tips and tricks for managing excision well. You always want to do a very detailed evaluation of the pelvis under high magnification, and you want to see where the lesion is compared to things like the ureter, the bladder, and the bowel. And I always jokingly say in my cases when I'm working with the trainees that once we've done the ureterolysis and we've dissected the bowel away, case is done. It's easy from there. So there's only a certain, structures that you want to avoid, and once you dissect those away, then it's much easier to go ahead and excise all the endometriosis after that. It's important to have a wide excision margin because there was one study that showed that there's even microscopic endometriosis up to about 2.5 centimeters away from your lesion. So if you can, and it's not always possible depending on the location, but if you can, it's important to try to get a nice wide margin. Hydrodissection is a technique I'll show you a video of where you can fill the retroperitoneal space with fluid, and that can protect underlying structures so that you can more easily dissect the peritoneum off, and some people also use this when dissecting ovarian endometriomas as well. Traction and countertraction is very important in endometriosis surgery because it allows you to see the planes and better dissect the peritoneum that's containing the endometriosis. And I always like to demarcate, and you'll see in one of the videos, I demarcate the area I want to dissect because once you start dissecting, it gets a bit hard to remember sort of where you're at, and you can end up taking out not enough or too much of the area that you wanted to take in the first place. And also, I always like to work away from structures that are important. So, go closest to the bowel and work away. Go closest to the ureter and work away so that you're not all of a sudden disoriented and then you're into the bowel or ureter. So I like to make sure I work away from those structures. So here's an example of hydrodissection. And you'll see that the uterine artery is just to the left. So I make a small hole and then fill the retroperitoneal space with fluid, and then that protects the vessels beneath me. And then I demarcate. The endometriotic lesions here are pretty subtle, and our cameras at Sunnybrook are terrible, as you can see. But there's some white fibrotic lesions that I was dissecting and removing there. And you can see how if we were ablating, because this tissue is so close to the uterine vessels, it'd be very difficult to adequately remove all that endometriosis. So it highlights a benefit of excision versus ablation. And then this is another example of excision and how we want to always think about the ureter. And I don't only think about the ureter because my husband's a urologist, but it helps because I'll feel really bad if I have to go home and tell him that I injured the ureter. He says the bladder's forgiving, but the ureter is not as much. So I take that very seriously. So it's helpful to perform ureterolysis, and some people will access it retroperitoneally or transperitoneally. I'll show you an option of how to access it transperitoneally. But I think that even in the easy cases, if you make it part of your habit to just practice ureterolysis or even in laparoscopic hysterectomy, then you get more comfortable. So if you do that in the easier cases, then you can build up and do it more comfortably in some of the more difficult cases. And I think it's like a nice skill that you can try to carry out. So I always make my incision right over the ureter, and that's just because I use the CO2 laser, and there's a very small depth of penetration. And so you can see the ureter peristalsing here, but you can also just pick up some of the peritoneum lateral to the ureter and open it with scissors or monopolar energy so that you can then dissect the peritoneum. I keep the ureter under my suction irrigator all the time so that I know it's safe, and then I can transect the peritoneum overlying the ureter all the way down until it crosses under the uterine vessel. And that way I know where it is at all times. And then it also makes it much safer. And again, this is the benefit of excision surgery, is that you can remove the endometriosis even when it is close to these important vital structures. Whereas you wouldn't be able to confidently do this using ablation. Plus, if you get into bleeding, it's always nice to have your uterus dissected first, and then you can coagulate any vessels, and you're not worried about, finding the ureter when you're in a panic and things are bleeding. You've done it ahead of time. And you can see how the traction and counter traction also makes a huge difference here. And that uterine artery is right below where we're operating, again, highlighting how excision really allows you to remove the endometriosis in its entirety while maintaining hemostasis and avoiding injury to structures beneath. So, even though I practice excision surgery, there's a role for ablation. So I will sometimes use ablation if it's a long case. I like to be efficient and save time when I can because I'm very meticulous and I take a lot of time for a lot of other things. So sometimes I will do ablation if it's just a solitary lesion and it's easy to ablate and avoid that. You can see there's no underlying structures that are important, but it's also can be very helpful on certain structures like, the uterus, fallopian tube. So I'll show a video here where you can see there's some endometriosis near the end of the fallopian tube. It would be impossible to excise this off the fallopian tube. But here you can ablate and get rid of that endometriosis, and you can almost see the scar in the tissue sort of released as you get down to that normal tissue underneath. And so there is a layer that's superficial where you won't get into bleeding because you're just treating the endometriosis. So another question. A 28-year-old patient presents with a 10-centimeter right ovarian cyst, which has features on ultrasound consistent with an endometrioma. She has a history of significant dysmenorrhea. How would you manage this? So hands up for those that would recommend laparoscopic drainage. Oh, thank you so much. Okay, B, recommend laparoscopic drainage and ablation. C, recommend laparoscopic ovarian cystectomy. Okay, great, lots of hands. And D, recommend laparoscopic unilateral salpingo-oophorectomy. Another sigh of relief for me, thank you, okay. Because I saw, in my training, a lot of patients young patients that might have had an oophorectomy. So I'm so happy that nobody offered that up. And there's some newer techniques also that are described in the literature that are not in this question, but are more investigational. Such as sclerotherapy, for example. But they're more investigational at this stage. So I want to talk a little bit about endometriomas because I think it's a very difficult and nuanced topic within surgical management of endometriosis. And as most of you know, an endometrioma is a cystic mass arising from ectopic endometrial tissue within the ovary, or quote-unquote chocolate cyst. And the decision making around endometrioma surgery is a hard one, and it's hard to sort of sift through and decipher the literature. But the two main reasons to treat endometriomas are pain and infertility. And obviously there's other considerations such as ruling out malignancy, or sometimes when they're so large, you worry about cyst rupture. There's less concern about torsion in endometriomas because they're usually stuck, but that's not to say they're always stuck, so they could still tort as well. And whether or not to operate is a balance, and it really depends on so many factors, both patient factors and I think it's really important if you have a young patient who is interested in fertility preservation, and then it's important to involve REI early in the management decision-making, and I always refer to fertility specialists when I'm trying to make this decision because they may have other factors that are affecting their fertility outcomes, such as age, male factor, and so I think you have to look at the whole picture to know how to, what to recommend to the patient. And the advantages of surgery are that we can confirm a diagnosis if there's any concern about malignancy, pre-malignancy. It will help the patient with pain management. And in some cases, if the endometrioma is really large or depending on the position, if patients are planning to undergo IVF, it can be very difficult to access the follicles. And so that may be a consideration that the fertility specialist recommends having the endometrioma out. The largest disadvantage is that we definitely decrease ovarian reserve. And even again, as meticulous as we are in dissecting out the cyst from the ovary, no matter how great of a surgery you do, all of us are going to diminish the ovarian reserve for the patient. And so I think we have to take that into account. And the bottom line in terms of fertility is that we know that removing an endometrioma can improve spontaneous pregnancy rate in subfertile patients. However, if they're planning to have IVF for other reason, it can improve ovarian stimulation, but it doesn't translate to an improvement in live pregnancy rates, and it can decrease ovarian reserve. And so we do not recommend removal of asymptomatic endometriomas prior to IVF. But if they have significant pain, if there's issues around access to follicles, then those are the nuanced decisions that you have to potentially work with a fertility specialist to decide on. The other important thing is that, and definitely when I was in training, I saw this where you have a patient, they have an endometrioma, the staff would say, oh, we're just gonna do a simple ovarian cystectomy today. And then you get into the OR and there's a mess of endometriosis and it's stage 4 and it's very complex and they weren't prepared. And so you have to be prepared that if there's an endometrioma or bilateral endometriomas, there's going to be significant endometriosis in the pelvis that you're going to have to deal with. And so be prepared to deal with that in your center. And I always highlight this study because I think it's important to recognize that. And this study looked at all patients coming with endometriosis. And 61 of 295 patients that they saw prospectively had endometrioma. And 77% of the patients that presented with an endometrioma had bowel involvement versus 21% without. So there's a markedly higher chance of having bowel involvement. And if you have bilateral endometrioma, that's even higher. So you should really be prepared that you may need, get into the bowel or need help from a general surgeon at the same time as surgery if you can't manage that on your own, to just be prepared for that and make sure that you have that availability and resource at your center. Otherwise, you may want to think about referral to another center or another surgeon. And then there is a Cochrane review that looked at what's the best ideal way to manage endometriomas. And I was happy that none of you said aspiration alone, and that's because almost 90% of patients who underwent aspiration alone had recurrence of an endometrioma within 6 months. So we definitely shouldn't be going in and draining. And I also usually recommend not to go in and drain if you encounter it unexpectedly. It's better just to look, document your findings, take pictures and video if you can't manage it right at that time, and refer on. Because if you end up draining it, it can go all over the pelvis, and then it makes it a lot harder for the next person to then surgically manage it in the future. So it's a good idea to just go in. Obviously, the best thing is to know ahead of time And I know my colleagues this morning also talked about diagnosis and improving ways and strategies to know what you're getting into ahead of time so that you don't encounter. But there is still going to be times where you encounter stage 3 or 4 endometriosis unexpectedly, and if that's the case, best to document video, photos, and refer on if you can't manage all of it at one sitting. But we know that excision of the endometrioma is a better technique than ablation because it has been shown to reduce the recurrence of endometriomas, less requirement for further surgery, reduce dysmenorrhea, dyspareunia, and non-menstrual pelvic pain, and can increase the rate of spontaneous pregnancy, as I mentioned, with patients with subfertility. So I want to now give you some tips and tricks for performing ovarian cystectomy. This is a very short clip. And whenever I think about managing an endometrioma, I think about my mentor who taught me everything I know about endometriosis, Dr. Kai Lee. And when we were in the OR trying to find the plane of the cyst wall, the most important thing is finding the plane between cyst wall and ovary. So he would then always yell, "Da plane," from Fantasy Island, which is a very old program. But this always reminds me of that, so. Oh, there's no sound. Oh, here it is. So that was like from the intro of Fantasy Island. So, and now you're gonna remember this, that the most important thing when performing ovarian cystectomy is to find the right plane. And the reason being is that if you are not right at that good plane between cyst wall and ovary, you can end up stripping a lot of normal ovarian tissue. And what that does is it removes follicles and removes good ovarian tissue and eggs, but it also then will cause more bleeding. And then you end up having to manage the bleeding and further destroy good ovarian tissue. So, and it makes you more frustrated. So I also experienced, in training many ovarian cystectomies where it was like, you grab the cyst and I'll grab the ovary and then pull as hard as you can. And let's get this out as fast as possible. And what that does too is it strips the ovarian tissue away, causes more bleeding. And you might get the cyst out really quickly, but then, it could take a long time to manage the bleeding at the end of the case. So I always recommend to stay very close to the plane between cyst wall and ovary so that you're just making small movements to remove the cyst. And I always use a blunt instrument on ovary and a tooth on the cyst so that I get better traction on the cyst, but I don't want the tooth to damage the ovary. There's no cyst that's too large. This is a common misconception too, that, it's so big that there's not really any good ovarian tissue. No matter how big it is, it will go back to being an ovary after. So you can always save that ovary. And we've done, 25 centimeter and cystectomy, and the ovary looks great and there's still function afterwards. So it's definitely feasible. Try to minimize thermal damage to normal ovarian tissue. So I use a microbipolar cautery to limit the amount of cautery, but if I do get into any more significant bleeding, I'll consider laparoscopic suturing. And there's other studies that look at sealants, for example. And so here's a little video about endometrioma cystectomy. And again, I credit my mentor, Kai Lee, for teaching this technique. So the first step always is, as I mentioned, most of these will be adherent to either the back of the uterus, the pelvic sidewall. So it's really important to first normalize anatomy and if it does leak, which it often does, always does, because of the pathophysiology and the way that these endometriomas grow, try to minimize the amount of endometrioma content that leaks through the pelvis. So I rapidly controlled that to try to minimize spread of the endometrioma throughout that could implant later. And then it's always important to be cognizant of where the ureter is because they can be very, very closely associated with the ovary. think about performing ureterolysis if needed before the dissection, and then normalize the anatomy and get the ovary off the sidewall, because if you don't and then you get into bleeding or trouble at the base of the ovary, you could easily cause a thermal damage to the ureter if you leave the ovary stuck to the sidewall or one of the vessels and get into a lot of bleeding. So I always release all of those adhesions first. And then once it's completely released and the endometrioma content is suctioned, we try to find the plane. And at the edge, it's often hard to do that because it's very, very thin. So I score the base of the ovary until I see the pearly white of the ovary. And you can do this with L-hook as well to score the cyst wall. And then you can see those two white areas. That's when I know I've gotten to normal ovarian tissue. So then I can further develop that plane and start dissecting the cyst wall from the ovary. I also use a lot of irrigation so that I can see the plane and keep things clean. Plus, if you have less clot that's in the pelvis, then there's less inflammation afterwards, theoretically less adhesion. And then here you can see that we go slow at the beginning until we find that plane. And then once you find the plane, the blunt grasper on the lower side, it has ovary, and that's just pointing to a follicle, and the bands there are ovary. So we try to grasp those and hold those spots so that you preserve the ovary. And Kai would always say to me, protect the ovary, protect the ovary. So that's always in my mind as well when I'm doing these. And then you can see we stay really close to that plane between cyst wall, which is in the upper part, and the ovary. And I think it's sort of a common misperception that these are very sticky and that they always have to bleed. I think that's true if you're not in the right plane, but if you find that good plane between ovary and cyst wall, they can actually come out quite smoothly. The recurrent endometriomas, however, are much harder to remove. So as I mentioned, suturing and hemostatic sealants can be a good option if you do encounter bleeding. And certainly if you are in the right plane and there's less bleeding, then less cautery, and you can consider microbipolar cautery as well. One meta-analysis did show that there was less decline in AMH levels with using suturing and sealants. And endometriomas recur, and so it's really important to consider medical suppressive therapy, and the ESHRE guidelines also recommend use of medical therapy after surgery for endometriomas, which can be very helpful because second surgeries have considerably lower AMH levels, higher basal FSH, and lower antral follicle count. So I really caution performing a second surgery if somebody wants to get pregnant in the future. And I'll just say a little bit about deeply infiltrating endometriosis because Dr. Kobyliansky will be going into a little bit more detail in the next presentation. But deep endometriosis is a whole other ball game that often requires multidisciplinary management and a multidisciplinary surgical team. And this is when the endometriosis invades, structures like the bowel, bladder, ureter, or chest wall. And you can still potentially treat patients like this with medical therapy, and it really depends on the symptoms, whether or not they would like to conceive, if they're, what their history's been like on medical treatment. But I've had a lot of patients, even with ureteric obstruction, ascites, very significant symptoms, recurrent hemothoraces, that do very well with medical suppression. So you can definitely consider it. These things are not always indications for surgery. And again, a multidisciplinary approach is key. So for the GI tract, when we're considering surgical management, it really depends on the size of the lesion, and that's when it's really helpful to have general surgery involved, and I'll often refer to my general surgery colleagues to plan this ahead of time. And most of the recent literature shows that shaving of the bowel lesions is preferred over disc resection or segmental bowel resection because of less complications. But it depends, because some of the disease can't be removed completely by shaving or disc resection. So you really have to balance the patient's goals because these surgeries have very significant risks. And I usually quote patients up to about a 10% chance of needing some sort of bowel repair or surgery with significant complications. And similarly with the GU tract, important to plan with our urology colleagues to determine what's needed. And sometimes, again, we can shave, but if there's intrinsic lesions of the ureter, for example, where the endometriosis is actually in the wall of the ureter rather than just compressing, those are cases where we would sometimes need to have urology remove a portion of the ureter and either do a UU reanastomosis or a ureteric reimplant in the bladder, plus or minus a psoas hitch. So those are sometimes complex decisions that can't always even be made preoperatively. Even with MRI, you may not be able to plan ahead of time, and it depends a little bit on what things look like intraoperatively. And the patients need to be counseled about this significantly. And as mentioned, the complications range on average about 10% with these very significant deep endometriosis lesions. So in terms of definitive management, I just wanted to touch on it briefly, that in the past, it was often recommended for endometriosis patients to have a hysterectomy and their ovaries out, and this would quote unquote cure the disease. But we know that that's not necessarily the case, and menopause comes with a lot of significant issues for patients and long-term health impacts. And so I tend to not usually recommend BSO unless it's somebody, when you balance the pros and cons, makes sense for them. And certainly in younger patients, and there's not a huge difference if we do a hysterectomy and remove the ovaries or not, as long as you're taking out all the endo at the same time. And however, in patients under the age of 40, one long-term study showed that there was actually no difference in rate of reoperation, whether the ovaries were removed or not. So certainly in that younger population, I always recommend that they keep the ovaries in. And it's really important to consider adenomyosis, because I see patients, they've had multiple conservative therapies for endometriosis, and they're not getting any improvement because people have overlooked the fact that they have adenomyosis too. So that's a subset of patient where hysterectomy may really benefit them, but it's also important to remove the endometriosis at the same time. And again, as my colleagues have mentioned as well, very important to then consider long-term medical management to help prevent the chance of recurrence of pain following surgery, because we usually quote about a 50% chance of recurrence of pain within 5 years after surgery for conservative surgery. So very important to emphasize the fact that endometriosis is a lifelong chronic condition and manage it as such with medical therapy. So to summarize and give you my take-home points, it's important to consider excision surgery, especially for endometriosis that may be close to certain vital structures. Make sure you remove the entire lesion with wide margins. Traction and countertraction is very important. Know your anatomy, work away from those vital structures. While removing an endometrioma, make sure you utilize fertility-preserving hemostatic techniques. And multidisciplinary management of deep endometriosis is key, with a thorough pre-op workup to optimize surgical success. Thank you very much for listening and being such a great audience, and I welcome any questions that you have.
Great, thank you so much, Dr. Kroft. So online as well as in person, if anybody has any comments or questions. So Dr. Allaire?
Thank you, Jamie. I always love, watching my colleagues, what they're doing across the province. And that was a great talk. Thank you. As I've been around for the block for a while, it's rare that something changes my, I always wanted to go to a lot of meetings and it involved my practice and my surgical practice. And one thing that has affected my surgical practice positively, I think, is the use of dilute vasopressin for endometrioma removal. I find that's been a game changer in terms of finding the planes, but also diminishing the need for hemostasis of any kind. So I just want to hear your comments about that. And then the other comment I was going to make is, I agree with you that if someone's going in on an elective surgery and finds really terrible disease, that the best thing to do is to back out and to not start dissecting the planes, because that's what actually can upregulate pain and patients can actually be worse off. And we see that all the time. I think it might be a little different in an acute setting when someone's on call, patient comes in, has a large cyst, goes in, and at that point, I think it's reasonable to drain because there's often infected endometrioma, something more going on, and to drain but not start dissecting, and then to suppress and then send to a colleague because you're in there already. So it doesn't make sense to me to leave a large cyst that's brought the patient acutely to emerge. So maybe you can kind of clarify what you meant by that. Thank you.
Thanks so much, Catherine. And actually it brings up, so I'll answer in two parts. So with respect to the dilute vasopressin, I know a lot of people do that and it works very effectively. I just never have in my practice based on the way that I was taught. And I also find, but I think if I would consider it if it was one that I was having a hard time finding the plane. And the other thing I didn't mention in this talk, but that your group does a lot, and I've said I want to do, is the ovarian suspension. And I think that we should be considering that and doing that more frequently to try to avoid adhesion formation afterwards. So the ovaries get suspended with suture that's tied outside the abdomen with like a little guard to protect the skin, and then it's cut about a week after, and then that just allows the ovary to heal without adhesion, because there's a very high chance of adhesion formation in the ovaries to the pelvic sidewall. And I know your group's presented a lot on that, so that's a great technique too. With respect to the drainage, I think it really depends, and that's a good point, like how symptomatic the patient is, how big it is, whether you think you can drain it and contain it rather than it going everywhere. And also, I have seen quite a number of patients with infected endometriomas, and that's one of the more difficult things to manage and treat. And I've had patients where we suppress them and treat them conservatively with antibiotics, and they've been in pain a year, and when we finally go in, it's still filled with pus. And it's like no wonder that they've had such significant pain. We see it often in patients that have sonohystogram or egg retrieval, and then they get an infected endometrioma, and those can be very difficult to manage. So certainly if somebody is acutely unwell and you go in or have very significant pain, then I don't think it's unreasonable to drain, as you say, and then it's very important to put on menstrual suppression post-operatively for many months before you'd consider doing a definitive surgery. And I would not try to do a cystectomy in an acute situation like that, especially in the infected endometrioma, and often those are hard at any point to do a cystectomy on, and I've had to do oophorectomy for a number of these patients with infected endometriomas, unfortunately, because they're too, they bleed too much, they're too infected, there's not much you can do from a hemostatic perspective at that point.
I do think that that's a great point. Thank you, Catherine, for bringing up the infected cases. I've had a couple patients try to die on me with infected endometriomas, and during COVID, saw quite a few of those patients who were really delayed. I think in the future, we should talk about the urgent or emergent rupture, infection, DVTs that have happened after these cases. There's a whole another world of endometriosis. Great point. Next question.
Hi, thank you for your talk. I'm Anka Matei. I work in Almont. It's a community practice. I just was looking for your thoughts on a negative laparoscopy. So we take these patients in because whatever indication brings them to the OR, we look and we don't see anything. And the teaching in my residency several years ago was to irrigate the pelvis copiously and then suction it out in an attempt to theoretically remove any inflammatory cytokines or whatnot. I guess, what else could you do? And I was wondering what your thoughts were on that, if there was anything else we should be doing in those situations, and how do we manage the patient after? Thank you.
Thanks for your question. I was never taught that. I don't know if there's any evidence. I've never come across any evidence that would impact, but I really think then it goes well into Innie's lecture that she gave about just validation of pain. And I see patients, it's rare that I go in and there's no pain, because I find that patients that have primary dysmenorrhea usually respond very, very well to medical suppressive therapy. But, in the event that you take them, and we've all had patients where we take and there's a negative laparoscopy, I think it's really important to and then the patient's upset. They almost are upset that they couldn't have something to more easily treat their pain. But I spend an extensive amount of time counseling how endometriosis is a chronic condition. There's no cure. Surgery is not a cure. And so, and I validate them to say, whether you have endometriosis or not, you have painful periods, treat the painful periods, use suppression, feel better. So if they don't have endometriosis, it's to say, you don't have endometriosis, but you still have really painful periods. So there's no reason to go on with that, and you should pursue medical treatment. And so it's just supporting them, and I still continue managing those patients just with medical treatments instead.
And I just wanted to bring back, Anka, before we go to the next question, back to Matthew's talk on the negative laparoscopy. I think, so Jamie and I wrote the section on diagnosis with surgery, and there are limitations. And so I think at the end of the day, I'd want to say that's no longer the question of a negative laparoscopy. It's all the pieces. Was there advanced imaging done? Was there other evaluation done? And at the end of the day, there are going to be cases where I've seen it, you've seen it, that people have missed the deep endometriosis that wasn't identified at the time of laparoscopy. So I think it has to link to our earlier one. Before we rule out endometriosis, if everything else is pointing to that, is to have the full evaluation and make sure that that's done. And then we unmask the other causes of pain. So I'd be careful that that's what we wrote in the guideline, that we may miss it. I don't know if you want to add anything else, and I'm sure Innie will have another point.
Yeah, I think the question of negative laparoscopy is really interesting and important, and I agree with Jamie's approach completely. And I know that with advances in ultrasound and imaging of endometriosis, hopefully it will be less and less common. But there are patients that we do take to the operating room sometimes where we cannot visually see any endometriosis lesions. And for those patients, in my experience, they would still benefit from medical management with hormonal suppression. We also have to keep at the back of our minds the other pain contributors, and the majority of our patients do have myofascial pain as well if they have chronic pelvic pain. So what I've done for these patients in the operating room is do a concurrent ilioinguinal and pudendal nerve block to help treat the myofascial pain while they're under general anesthetic. I do tell the patients that's what we're doing, so that if they feel better after the surgery, it could be because of the surgery itself, or it could be because we did something also to treat another pain contributor, so not necessarily because of the endo. And also that preoperative counseling for what to expect after surgery, and helping them be open to the diagnosis of to the possibility that we won't see any endometriosis. I think that's really important as well.
Thanks, Annie. And yeah, I think further to what Sony was saying too is like to be on high alert and high lookout for anything that looks abnormal on your diagnostic laparoscopy. So identifying the subtle lesions that are vesicular or fibrotic. So I'll take out anything that possibly looks abnormal, and that's where the excision of that is really helpful, because it may just look like, oh, that's nothing, but then it comes back as endometriosis. And to also make sure you're looking under high magnification and using irrigation, and you can move the peritoneum to, you get a better sense of like if there's even a small vesicular lesion can be consistent with endometriosis.
And just one more thing I'd really like to add is, because we see a lot of the rare stuff, is that pinpointing where the pain is. You can have a negative laparoscopy. I just operated on a patient with fibroids, and her endometriosis was not in her abdomen. It was along her abdominal wall, a massive abdominal wall endometrioma. Good segue to the next talk. So you could totally do all this, and meanwhile, her actually was in her cesarean scar. It was somewhere else. There's a whole bunch of stories. Hernias, seeing a lot of that. So I think at the end of the day, it really behooves us to really think about that. And I think the negative laparoscopy discussion is, we have to think about that for the guideline. It'll be negative complete workup, you know, including imaging, not just for endometriosis, adenomyosis. And that brings me to a quick question for everybody, because this was brought up, was when you have an ultrasound, how many centers are you getting the MUSA criteria, M-U-S-A, adenomyosis classification of endometriosis when you get your ultrasounds done? How many of you are getting the reports? I'll just say it again. So the worldwide recognized approach to how adenomyosis should be classified on your ultrasounds for MUSA. I'm doing it on purpose because none of us are. It's available, and it's crazy that we're not talking about it. And did you also know we have a endometrial cancer diagnosis we can do on ultrasound? We can actually look at the endometrium. There's a whole classification for that as well. How many of you have had an ultrasound showing endometrial cancer diagnosed on your ultrasound, you know, just like we're talking about it? So the point is, back to the initial point, imaging is so far ahead, and we're about 10, 20 years behind implementing it. It's just relating the conversations to the earlier morning. So Jamie, because our next speaker has told me to let you go longer because she really likes listening to you, is there anything else you want to finalize and add in terms of any of the comments?
No, but we'll have a great panel in a little bit after, so you can.
There was one question for you,
Yeah.
actually, I forgot. Do you use anything other than the suspension? Do you use Interseed, other things for adhesions?
I will sometimes use Interseed depending on, like an adhesion barrier, depending on the patient and the goals and how much dissection that I do. Yeah.
Okay. Well, thank you, and I'll invite my next speaker up in a moment.